Muted.
So today's talk will be on uterine artery Doppler. This will follow with the basic umbilical artery Doppler and then move on to advanced fetal Doppler, including MCA, Ductus venosus, umbilical vein Doppler. I will talk you through some of the pitfalls in obtaining good Doppler traces. There will be a do and don't summary at the end, and hopefully we'll have some time for some questions and answers. So this is really a talk on fetal Doppler from a sonographer's perspective. Obviously, fetal Doppler is used in a clinical setting on evaluating the fetus. But from a technical point of view, from a sonographer, as far as sonographers are concerned, that's what I'll be touching on today. So as we all know, fetal Doppler, pulse Doppler is used in the assessment of fetal well-being from the early second trimester onwards, and can also be used in prenatal aneuploidy screening. And advanced Doppler especially should be performed really by experienced obstetric sonographers if possible, and we follow strict criteria when performing advanced fetal Doppler. So I'd like to start with talking about uterine artery Doppler. Even though it's not strictly a fetal Doppler, it does address uteroplacental function. So it is a dynamic evaluation on the maternal side of the placenta and reflects the degree of resistance to flow in the uteroplacental circulation. So in a non-pregnant or early pregnancy state, resistant in the uterine arteries, resistance to flow is high. As the pregnancy progresses, resistance decreases. And persistent high resistance raises the chance of preeclampsia and IUGR, and I think 70% chance of preeclampsia and 30% of IUGR. So when do we perform uterine artery Dopplers? We perform in at-risk pregnancies. These include patients with chronic hypertension, history of preeclampsia, IUGR, patients who've had a donor embryo or egg, and in autoimmune disease or acquired or hereditary thrombophilia. And we also can perform uterine artery Dopplers in early onset IUGR, early onset defined as less than 28 weeks, and it can help us to differentiate between uteroplacental insufficiency IUGR or a viral or aneuploidy type issues. And also you can perform uterine artery Dopplers when the papa is known to be low. So uterine artery Doppler technique. So this is very important to measure correctly and know where to measure. So it's measured at the crossover of uterine artery and internal iliac artery. We must use the zoom function, use color Doppler to identify the vessel, use a wide Doppler gate to ensure measurement of maximum velocities through the uterine artery. We measure both sides, obviously. We use angle correction. And last but not least, remember to adjust the scale to optimize the visualization of the waveform. So first image shown here, and I'm hoping everyone can see the pointer. So we can see measured at the crossover of uterine artery and internal iliac artery. So internal iliac artery is just here. This is the vein. You can see the uterine artery. We use a wide Doppler gate to make sure we measure all the velocities. There's angle correction. If you're having trouble in obtaining a clean trace, you can ask the patient to hold their breath. And remember to adjust the Doppler scale to optimize the visualization of the waveform. And I talk about 2/3 so that the waveform fills 2/3 of the scale. I have a video that shows what I've just described. So we can see here we've used the zoom function, color Doppler to identify the vessel. put a sampling gate with angle correction, and run the trace. So how do we interpret the uterine artery Doppler? Well, a normal Doppler is characterized by an RI, which is the numbers you get when measuring the between the S and between the S wave and the diastolic flow, systolic and diastolic, and it's RI less than 0.55 indicates low resistance, and there's no. And the patient that has a uterine artery Doppler with a waveform like this, low resistance, no notch, is at less than 1% chance of developing preeclampsia or IUGR later in the pregnancy. This is an abnormal uterine artery Doppler, which is characterized by an RI of greater than 0.55, you can see number here, indicating high resistance, 0.55 on both sides with a notch, or on single side RI greater than 0.65 is considered high. But in the case of a unilateral notch, we need to document the side of the placenta, because if the side of the placenta is on the opposite to the side where there's notching, it might not be relevant. And a patient that shows high resistance with notching is at risk of developing preeclampsia and or IUGR. Okay, so on to fetal Doppler. This is the basic Doppler, and it's umbilical artery. So currently the only technique in fetal surveillance that has been shown to reduce fetal perinatal mortality and morbidity. And it's done routinely in all third trimester ultrasounds, and it's the measurement of placental impedance to blood flow from fetus to mother. And of note needs to be made the point that for the umbilical artery Doppler to be abnormal, the flow impedance needs to be significantly compromised. So the significant part of the vascular bed will be obliterated. I think it's about 75% before a Doppler, umbilical Doppler, is abnormal. I was just encouraged to put this picture in by esteemed Dr. Peter Muller, one of the senior MFM specialists at the Women's and Children's. This is out of one of his presentations. This shows the a normal placental vascular bed, and this is one that's been obliterated, one where umbilical artery Dopplers rather were abnormal. So I'm sure everyone's very familiar, but I'll just touch on the umbilical artery Doppler technique. It needs to be measured in the middle of the umbilical cord, and by that I mean away from the fetal umbilicus and away from the placental end of the cord, so where the cord inserts into the placenta. The reason is that on either end the readings can be a bit funny, a bit unusual, and it might not be truly representative of how the Doppler really is. Because we are measuring resistive index, so angle correction is not necessary. If you're not getting a clean trace, you may ask the patient to hold their breath and remember, optimize the scale to better visualize the waveform. So interpreting the umbilical artery Doppler, so we have so a normal Doppler is characterized by low resistance, showing good forward flow in diastole, and these resistive indices. These are just numbers, but there are reference charts which I'll show in a minute. So for every gestational age, there is a tolerance, a normal range for all these numbers. So we have an abnormal umbilical artery Doppler. So this one is an increased resistance, where the forward flow in diastole has decreased, and the ST ratio and the RI and PI are high. Further on, this umbilical artery Doppler can further deteriorate by not showing any forward flow in diastole. So this is further increased resistance. And absent end diastolic flow noted when 75% of placental bed has been obliterated. And the last and probably the worst abnormal umbilical Doppler we see is the when the diastole has reversed, so a reversal of end-diastolic flow, and this fetus is 10 times increased risk of perinatal mortality. Sort of an end-stage finding, really. As mentioned before, so there's umbilical artery Doppler reference values, and I think it is a good idea for every ultrasound department that does obstetric ultrasounds to hold a copy. This is from the American Journal of Perinatology. So for every gestational age, there is a normal range, and early in the pregnancy, before sort of 30 weeks, the ST ratio or resistive index tolerance is quite high, more than people actually imagine. Likewise, there are some graphs. So this is the resistance index, RI, and the plots on the versus the weeks of gestation. So as you can see, further on the gestation, the resistance index drops, much like the ST ratio. So move on to the main topic of today's presentation, which is the advanced fetal Dopplers. So advanced Dopplers is an adjunct to the overall ultrasound examination, so it's not just done as a standalone study. As mentioned before, we use strict criteria, and it should be used when performing advanced fetal Doppler, and it needs to be used in the context of a clinical picture. And the reason is that unnecessary Dopplers are being reported that do not correlate with the clinical picture for whatever reason. So there's nothing suspicious, patients doing well, baby's growing well, fluid's normal, umbilical Doppler is normal, someone does an MCA and it's abnormal. It just doesn't make sense. So advanced fetal Dopplers include middle cerebral artery, ductus, venosus, and umbilical vein. And they're used in a surveillance of monochorionic twin pregnancies as routine, and a surveillance of fetal anemia, fetal IgR, and then fetal heart failure. At the women's and children's, we have an algorithm used for fetal Doppler evaluation. There's a couple of different versions, essentially showing the same. So depending on what we're trying to investigate, so say this is the Doppler we perform. So fetal anemia, we will do an MCA peak systolic velocity, investigation of a definitive IgR, so when there's a clear drop-off in growth, do an umbilical artery ST ratio, and MCA resistance index, plus or minus uterine arteries. And we would move on depending on how these Dopplers pan out. So if the umbilical Doppler had absent or reverse flow, we would move on to ductus venosus and umbilical vein. So small fetus versus IUGR, and if there was head-body discordance, fetal weight or abdomen circumference below the 10th percentile, or a clear drop-off in growth, we would do an umbilical artery Doppler, obviously, and an MCA-RI, and then move on to, depending on how the umbilical Doppler looked, whether there was absence or reversal of end-diastolic flow, we would perform the ductus. And in babies at risk of cardiac failure, be it in twin-to-twin transfusion or cardiomegaly high drops, we perform the MCA peak systolic velocity, ductus, and the umbilical artery. And in a normal growth and AFI babies, we only ever do umbilical artery Doppler. So some of the indications for advanced fetal Doppler. So as mentioned, it's used in a routine assessment of monochorionic twin pregnancies. And the protocol is for, on top of the growth, deepest pool will perform an MCA Doppler fortnightly from 16 weeks onwards. We'll do advanced Dopplers in suspected fetal anemia, suspected and unconfirmed fetal IgR, suspected fetal infection, risk of fetal maternal hemorrhage, preeclampsia, red cell alloimmunization, and surveillance of an evaluation of at-risk fetus cardiac failure. So we'll start with the MCA Doppler. And when we use it to evaluate growth restriction, we measure the resistance index, or the PI. And when we when we evaluate the fetus for anemia, we measure the peak systolic velocity. So we have a technique, a protocol. So the MCA Doppler is obtained just below the BPD plane at the circle of Willis. We always use the zoom function, very important. We place the sampling gate in the middle of the vessel. Let's interrogate the medial third of the MCA. Make sure you're not in the circle of Willis. No. Use angle correction, and we don't correct beyond 35 degrees. The measurement becomes a little bit, can become quite inaccurate. Adjust Doppler scale to maximize the waveform, and we try and use gentle transducer pressure, and I'll touch on that a bit later. So the Doppler technique, so we have the sampling gate in the middle of the vessel, interrogate the medial third, and show not in a circle of Willis. Use angle correction, which can be seen in there, and you obtained 2 or 3 traces, depending how comfortable you feel with the results you got. If they're significantly different, obtain a third. And remember, always adjust the scale. I can't stress that enough. So this is a short video showing MCA Doppler trace acquisition. So just below the BPD plane. Zoomed in, color Doppler on. Middle of the vessel, angle corrected, medial third, and we have a trace. So how do we interpret the MCA Doppler trace? Well, in the evaluation of growth restricted babies, the the PI or the RI resistance index will be reduced because the forward flow in diastole would have increased, which is suggestive of cerebral redistribution or brain sparing. So these fetuses, they're not growing well. They try to preserve the organs. They shun blood flow to the brain. We have an MCA resistance index chart. So for every gestational age, there is a tolerance level. So below the 5th centile, if an RI for gestational age is below the 5th centile, then it will be considered to be abnormal. In fetal anemia, so we measure the peak systolic velocity, and actually you can see in this image here, it was a very extremely difficult scan, and we used I used the distal middle cerebral artery rather than the proximal one, because the proximal one was very difficult to access, and the angle correction would have been beyond 35 degrees. So here's the distal one, which is still fine. So the peak systolic velocity in fetal anemia increases. Likewise, the fetuses shun blood flow to the head to preserve the brain, and also because it's fetal anemia, so there's less red blood cells, so blood becomes less viscous, hence it can travel faster. And we have MCA Doppler peak systolic velocity chart, centimeters per second, so we use the multiples of the median, so anything above 1.5 is considered to that may indicate fetal anemia. We have these pre and post transfusion charts. So when we measure, we will plot along gestational age and the peak systolic velocity. So anything above the 1.5 multiples of the mean will be considered to be of high resistance, and consistent, persistent readings in zone A, which is up above this 1.5 multiples of the mean line, will lead the clinicians looking after the patient to consider fetal blood transfusion. If a blood transfusion was to take place, Post-transfusion, the fetus now has adult blood cells, which are smaller than fetal blood cells, so they naturally travel faster. So the tolerance on the scale changes. So then the peak systolic velocity is allowed to be slightly faster. But we still monitor post-transfusion babies for their, make sure they're not stop being anemic. I guess. So ductus venosus Doppler is next. So ductus venosus, it's the main vessel for oxygenated blood from placenta to the fetal heart and circulation. So ductus venosus Doppler is mainly used in the assessment of fetal growth restriction, compromise of fetal cardiac output, and we perform it when umbilical Doppler is abnormal. And can also be, and is used in the screening for aneuploidies in the first trimester. So there are two methods of obtaining the ductus venosus Doppler. So one is in the sagittal plane, where color Doppler is used to find an aliasing vessel in the middle of the abdomen and interrogate with pulse wave. And the second method, which is the one I always use, scan in axial through the fetal abdomen, find the anatomical location of the ductus, use color Doppler to show flow and interrogate with pulse wave. And I found the second method always to be 100% reliable in knowing that I'm sampling the correct vessel. So technique again, we use the zoom function to zoom in, use color Doppler to identify the ductus venosus. We place the sampling gate in the middle of the vessel, and always remember, adjust the scale to optimize visualization of the waveform. So this ductus venosus technique video is in 3 parts. So first part is scan actually through the fetal abdomen, and we use the zoom function to zoom in. And actually, for the presentation, the video is quite compressed, but if you are on the actual ultrasound system, the resolution is so good, you can actually, a lot of the time, see the ductus between the umbilical vein and the IVC. So we put color on, and we're able to see the umbilical vein turning in there, and this is the ductus, so between the umbilical vein and the IVC. And this video is from beginning to end, so using zoom Doppler, the zoom first, sorry, color Doppler, pulse wave, gate, and then the trace. So let's have a look at some ductus venosus trace interpretation. So the normal ductus venosus Doppler trace is characterized by a triphasic flow pattern. So we have the first peak, which is the S wave, representing the ventricular systolic contraction. We have the second peak, the D wave, which is the early fetal ventricular diastole, and the A wave is the fetal atrial contraction. So in abnormal ductus, what happens is that the cardiac output is so compromised that the atria is unable to fill well, and you get either a deepening of the A wave, you get absence of the A wave, or like in this case, I'm showing here, there's a reversal of the A wave. So this Doppler trace here is actually a very sick baby. So ominous. This was an ominous sign of severely compromised fetus, and I think together with her pulsatile umbilical vein, the baby was delivered, I think, the same day, a couple of hours. And much like with the other ratios we measure in other fetal Dopplers, there are graphs available. So this one has the SA ratio versus gestation, and the SA ratio decreases as the pregnancy progresses. The final of the advanced fetal Dopplers is the umbilical vein Doppler. So in early pregnancy, the umbilical vein can be quite pulsatile and becomes non-pulsatile by the beginning, sort of by the end of the first trimester, beginning of the second trimester. And presence of pulsatility in the umbilical vein from the second trimester onwards can indicate severe pathological state. And if you show a true real pulsatility in the umbilical vein, it's an ominous sign of severely compromised fetus and really imminent mortality, although they have been shown to survive into the sort of 30-31 week gestation. So technique for umbilical vein really very simple. It's the interpretation that gets a little bit tricky because of fetal breathing, maternal breathing. Are there real pulsations in the umbilical vein or not? But we sample along the cord, much like the umbilical artery, so away from cord insertion and on both sides, the fetal and the placental. Likewise, use the zoom function, use color Doppler, place a sampling gate in the middle of the vessel, adjust Doppler scale to maximize waveform, use gentle transducer pressure, and ask the patient to stop breathing if necessary. So technique middle of the vessel, really, and adjusted scale just so we can see what's going on. And so interpret the trace can be quite tricky, as I mentioned before, but we've experienced, sonographers do get to recognize real pulsatility. So this is an abnormal trace characterized by a triphasic flow pattern. And fetal mortality imminent, really. So this baby was delivered in the next couple of hours after the scan, and unfortunately didn't do well. So now some pitfalls. First and most obvious one to me is fetal breathing, and can make the trace very irregular. Most of you will be familiar with how the traces look, fetal breathing, but you'll be surprised that often fetal breathing is taken as something abnormal with fetal heart, and we've had second opinion referrals put into us for traces much like this one, calling fetal arrhythmia and whatnot. So what do you have? What choice do you have? You can wait. You need to wait for the fetus to stop its breathing practice. If that doesn't happen, well, you just need to document that the baby was breathing during the Doppler trace. I know often radiologist is not available to come in or into the room to look at a scan in real time, so make sure you document. Another one is this is a Ductus venosus trace with a fetal breathing. So this can be a really, really difficult trace to obtain. You can just see the normal triphasic pattern here. There's one here. There's one here, and the rest is just fetal, the baby breathing. And yeah, it's quite difficult. So in this case, you either take this or you wait for the baby to stop its breathing practice, which can take some time, and I know people are under pressure to move on to the next patient. So next one is fetal hiccups. Likewise, much like with the fetal breathing, just need to be documented. If you don't have another trace or the baby is constantly hiccuping and there's nothing else you can do, just document that this was a hiccup to make sure that the radiologist reading the films or making the report doesn't misread this as something abnormal. Sampling the wrong vessel. Now this is obviously can have very significant clinical implications. So if someone's inexperienced or hasn't done many advanced fetal Dopplers, and I've seen this done. So someone is attempting to interrogate the Ductus venosus. However, they've got the gate in the hepatic vein. showing a reversal of the A wave, which is very abnormal, ominous sign. However, with experience, you would have known that either to repeat this or this is can't be right, and need to get to the bottom of it one way or another. So yes, apparent reversal of the A wave. However, it's just a normal hepatic vein trace. Sampling wrong vessel. So this is allegedly trying to perform uterine artery Doppler and showing extremely high resistance with showing postsystolic notching, which the person performing the scan has actually annotated as postsystolic notching. However, I think they were in the internal iliac artery. So this same patient was rescanned by an experienced obstetric sonographer, and this is the trace they got. You can see how the crossover, low resistance, and no evidence of any postsystolic notching, and not at risk of preeclampsia or IUGR. So this trace here actually had a clinical impact, because following this, the patient was scheduled to be seen twice a week. So I think when this one was performed, maybe the clinical picture had changed somewhat. And then we can have all sorts of funny sort of traces. This one was, I think one loop of cord was behind the other, showing sort of like a double. So just to, if you get this sort of trace, try another loop of cord to make sure that the radiologist doesn't read this as some kind of a fetal heart arrhythmia. So transducer pressure, so you will find with advanced fetal Dopplers, especially the MCA, if there's undue prolonged transducer pressure on the fetal head, the baby will feel compromised and will actually, as you're doing the couple of traces, will shunt blood flow to the brain, so it will vasodilate its MCA and will show a decreased resistance, much like you would get in an IUGR type scenario. So if this happens, you would, if there's no other signs of anything going askew, you would you'd probably just repeat the trace in a few minutes, give the baby a rest. You remember how throughout the presentation I was emphasizing the need to maximize the Doppler scale so you can optimize the visualization of the waveform. So this umbilical artery trace, you can see how the scale was not adjusted, and you can appreciate how difficult it would be to accurately measure an RI, PI, or an NSD ratio. So this showing a low resistance, and the same patient rescanned by an experienced obstetric sonographer optimized the scale, and you can see a significant improvement in the accuracy of measurement, with the results being quite different. And last but not least, obviously patient size, but there's not really much we can do about that. You need to use low frequency transducers, and you can ask the patient to roll onto the side. So in summary, we follow strict guidelines for advanced fetal Doppler. We use zoom function, use your color Doppler to identify the vessels you are interrogating, use angle correction when necessary. We place the sampling gates in the middle of the vessel, adjust the pulse Doppler scale, the 2/3 of the scale I mentioned, repeat the trace if you're unsure, and document fetal activities during Doppler acquisition. So fetal breathing, fetal hiccups, fetal movement, and remember the ALARA principle, because it especially applies in pulse wave Doppler, where the intensity of the ultrasound is 50 times. And if you have, like in MCA Doppler, you have a bone tissue interface, the heating effects can definitely be felt. And don't attempt measurements you are not comfortable doing, and don't perform unnecessary fetal Doppler, and don't place undue physical pressure on the fetus.